Science under ICMR. Her academic and professional journey reflects a rare blend of clinical acumen, epidemiological insights, and technological foresight. Prior to her current role, Dr. Dugal was additional professor of community medicine at Postgraduate Institute of Medical Education and Research, PGIMER, Chandigarh. She has also held adjunct faculty position at premier institutions including the Indraprasth Institute of Information Technology, Delhi, and the Indian Institute of Technology, Ropar, contributing to interdisciplinary education and research. Dr. Dugal holds an MD in Preventive and Social Medicine, a Master of Health Science in Epidemiology from the Johns Hopkins Bloomberg School of Public Health, and completed prestigious NIH Fellowship in Medical Informatics at Yale University. Her academic credentials are matched by over 2 decades of impactful work in public health research. Her expertise span community-based outreach, intervention design and implementation, epidemiological modeling, and translational research. She is particularly known for her work at the intersection of behavioral science, digital health, and implementation research, with a focus on reducing healthcare disparity among vulnerable populations. Dr. Dugal has served as principal investigator, co-investigator, and senior collaborator in numerous multi-institutional research projects. Her leadership has instrumental in field of implementation studies and impact evaluation, notably in the domain of food fortification in India. Her contributions have consistently translated research into policy and practice, advancing equitable health outcomes. So we are privileged to welcome Dr. Muna Dugal to Gyan course on food security, nutrition and innovation. Her presence brings a wealth of experience and a visionary perspective on integrating digital health and data science into public health strategies. So ma'am, thank you very much for joining us, and over to you ma'am. Thank you so much. Thank you.
Thank you, Dr. Teja. I'm not sure, can you, I'm just trying to share my screen.
Yes,
can you share my screen?
Yes, we can share. We can see your screen, ma'am. Just please it on full screen if possible.
Yeah, I tried. Yeah, is it big or it requires more?
Screen, ma'am. Screen is visible, but it is not in
very
full
small.
screen. Yes, full screen. So at the bottom, ma'am, there is one icon.
I'm presenting, and yeah. So let me just put it on full screen.
Yeah, no problem, ma'am. Please take your time.
Slideshow. Is it okay now?
Not yet, ma'am. Not yet. Yes, ma'am. We can see our screen. And
is it okay now?
Screen is visible, ma'am, but it is still not full screen.
I think it is full screen. Let me just let me put it on slide. Sure, that is better. Is it okay now?
Either we can zoom it, ma'am, so that we can.
Can you zoom it? I don't know. Is it okay now?
Ma'am, still it is not in full screen.
Can you do one thing? I think you have a presentation.
Yes, we can. Yes.
You can do zoom it. I can just
yes. Sure. No problem, ma'am. No problem.
I can stop sharing. Yeah. Dr. Tejpal, in the meantime, as we are setting the screen, just wanted to brief the audience out here quickly. I will be co-presenting with my the co-coordinator who has been working, Dr. Gurjinder, who has been working with me for a very long time now, around 5 years. So I think the presentation is generally around fortification, where our team has worked for a very long time. It's almost like we have done four major, at least we have two major fortification projects that we have worked on in the states of Haryana and Punjab. And the northern India, I think some of the population studies have been done majorly by our team at PGI. So, but as I am talking and Dr. Tejpal is presenting, uh, people who are sitting, I think you are young people, and I think research, just wanted to give you this. Research is never easy. It is a collaboration and conglomeration of multiple partners. So if you think I have done it, it is not. And if you have been reading the news today, the lady who has got the Nobel Prize just has 34 publications, and in H index, if you know, it's just 21. So this has been the big news that we all run after the number of publications, and but it is not important to run after publications. They are important, but what is important is the impact. So unless until you actually think about research as something that is going to have a huge social impact, and how you can do an interdisciplinary research, that is where I think the entire thing is going to be there. So through the presentation that we are going to do is, of course, it is around integrated planning, governance, and around food security. But the top three words itself say a lot. First is the planning, second is the governance, and third is the fortification. But everything has a big meaning as we are talking. And I want to leave you with the thought that this is not merely what we are presenting. It has to have a meaning when you are thinking about your own research projects and how you are planning your career, how it is going to impact your future, and what kind of work you want to do, and what is the legacy you want to leave after you have finished that research. So even if it is small, do it well. Don't say, okay, this is like very small, I will not want to do it. But this is something that I would request that as we are doing. Dr. Tejpal, has the screen sharing started? I am not able to.
Actually, we are trying, but what problem is coming that if we are sharing, then your video we cannot see. So we again request you to please start from your end so that it could
Okay,
be
I
both
will start
video.
from my
Yes,
end. Yeah.
just try.
Can you I don't know, I don't want people to if you want to share the PowerPoint with them so that they can look
Yeah,
at
definitely
their
will share them. No
yeah, so
issues
they
at
can
all.
probably look at the
Yeah.
PowerPoint as I'm speaking.
Sure, ma'am. Yeah,
Yeah.
please. No issues, ma'am. Thank you.
Yeah, can you share the
Yes, ma'am. Again, you
okay.
can.
Where did it go? Not कर Yeah.
Yes, ma'am. It is fine.
Okay.
Yes, ma'am. Please continue. Thank you.
Okay.
Thank you so much. Thank you.
Yeah. Uh, so as we are talking about this, it is integrated planning and governance for food security through fortification. So as I had earlier mentioned, this is an area that we had worked a lot. I think we started the journey around 2013. when this problem was identified in Haryana, that is a story of fortification and how it has built into the small project that has gone on to the national level and how much capacity building, governance, and health that has been done. So as I'm telling the story, I think you will understand. Like it is not a like it might seem small, but the amount of work that was done to make this whole process implementation, why it is important, and why small studies make such an impact. So, how many of you would know that like what are the biggest nutritional issues right now when we are talking about fortification and why fortification came into play? So, just a quick question. I think Dr. Tejpal, you can ask him why we had to start looking at fortification from the students who are attending this. Why did we actually had to start looking at fortification as a measure for food security? Does anybody have an idea?
Deficiencies would obviously lead us to want to fortify.
Hello? Hello?
Good morning, ma'am. Am I audible?
Good morning, yeah. Just a quick question. Why do you think that fortification was required as an intervention in the population?
In order to target the deficiency conditions that are being observed throughout the world.
Why did the deficiencies come through? What are the other programs that we are doing?
I'm sorry, ma'am. Could you please
What were
repeat
the
this?
other programs that we were doing that we needed fortification? Anyway, this is something that I would like you all to think about because
Another thing is, ma'am, malnutrition. To tackle the malnutrition.
Malnutrition is a very big broad word. Even you are malnourished.
Maybe.
No, maybe no. You look at the entire population. Malnourishment is both what? Undernutrition plus overnutrition, right?
Yes.
And why is it there?
Ma'am, basically, fortification is for undernourished children or the population.
You mean to say people who are malnourished, they who are overnutrition, they are not, they do not require any nutrients?
Ma'am, it depends what type of nutrients are beyond the limits and what type of nutrients they are
So that is the
undernourished.
first step that you have to now go back, look and understand what is malnutrition and is fortification supplements and what we talk about. Is it only for the people who are undernourished, and even if they're overnourished, do they meet the requirements that we are talking about? So fortification is what?
Basically, we are enriching the any food product with specific amount of nutrients in that. Suppose if we are fortifying salt with iodine, then in what amount of
So is iodine only a requirement for the undernourished, or is it a
no,
general
ma'am, there are
requirement?
many things like vitamin A,
Yeah,
vitamin
that's why I said
D.
think about it. Why do we have come to such a stage that we require fortification? Is it the soil? Is it the environment? Is it our lifestyle? What is it that we require fortification now as an intervention? Compared to probably like when people were probably growing their own crops, what has happened since then that we are now looking at fortification as an intervention? So this is something that when I finish my lecture, you people should go back, listen, see your environment. The only thing you think is like it is a last mile, it is a rural population, or it is like a certain specific population that would require fortification. No, it is something that is required across the populations. So think about yourself, the people who are sitting in the class. Why do we have always say now the elderly population requires? It is a young population, it is a mother. No, it is across. So you have to start thinking in that and think about it. Is it the new lifestyle that you are like? How many times do you order your food from like Zomato? What is the kind of food that you are eating? So this is not about this. The reason I'm saying this is because I need you to think. It is not that I come, I teach you. This is not going to happen. When now I'm talking, I really want people to think that, see why we really need this, why this intervention was asked to be there at the first place. What is food security and why we are looking at interventions that should not have been there in the first place. What has changed since then? Has our soil been depleted? Has there been an increasing urbanization? Have we stopped using? Has there been an increased use of pesticide? All these things will actually make you think not just what we have done, but what is the new research question. So coming to the lecture is like let's start from there. 30% of the women from reproductive age are anemic. Prevalence of anemia among women of reproductive age has remained stagnant over the past 2 decades. Despite government putting a lot of money in supplementation and everything, the prevalence of anemia among the women of the reproductive age has remained stagnant and over the past 2 decades, we have not been able to maintain them. 69% of the non-pregnant women of the reproductive age group are deficient and in at least one of the three micronutrients, iron, zinc, and vitamin A. 307 million of these non-pregnant women with reproductive age group with micronutrient deficiency live in South Asia. So, in 2013, when we had started with this, Haryana had one of the highest micronutrient deficiency and anemia in northern India. And that had a direct impact on the birth defects of the children that are being born. So looking at that, I think with the prevalence of anemia and micronutrient deficiency and the supplementation not really working in our favor, the government of Haryana actually started looking at other options. What were the options that could improve at a large scale and an intervention that was actually well documented across the world that could make that difference? So in 2013, this is around the time when I actually was looking back in India with probably no experience whatsoever in nutrition. Had returned from the US, and this was a project that came like as a first project in 2014 when my head of the department, Professor Rajesh, actually asked me to look at this because an interest had come from government of Haryana that they wanted to actually do a demonstration project around fortification as an intervention to improve the overall nutritional status of women as we are looking to decrease the birth defects of the babies that were being born. So that overall goal, this was something that was actually identified as a fortification. Fortification was identified as a mid-term intervention in addition to the ongoing supplementation to improve the overall micronutrient status in the population. So what had happened was the supplementation was being implemented through the health systems and it was a fragmented implementation and weak outcomes. So what was required at that time was it was a need for multi-sectoral convergence that required health, food, education, agriculture, women and child health and academia to come together, including a strong advocacy component that we had required. There needed to be a strong monitoring and accountability in the frameworks, and there was an equity lens that required we needed to reach the women, children, and overall marginalized communities so that the intervention would make a change. So, for starting this project, we required a state level planning, which required the initial ask was from the National Health Mission with a state level planning of food and civil supplies, with integrated child and development scheme and the midday meal. There was a need to have a convergence with the district level convergence committee, community level participation and an awareness campaign, and a data from the community biomarker study that was going to be done by academic partner that is PGI Chandigarh. So overall, once that setup was converged at the level of PGI in collaboration with Government of Haryana, where we have several departments, we took the interventions that required collaboration even with the NGOs who were well entrenched in the field. So the first project that I will be discussing is the wheat flour fortification in Haryana that assessed impact on folate, B12, anemia and iron status. The project started in 2014 and it ended in 2021. Second was multiply fortified salt study in Punjab that is evaluated the effects of micronutrient biomarkers among women and it started in 2019 and it ended last year. Third is rice fortification with the establishment and the implementation of a technical support unit in Haryana. It is an ongoing project where we have established a technical support unit to improve the rice fortification quality and implementation in the state and at the level of uh, uh, the state level, and it is again in partnership of PGI along with this government of Haryana. Last was a study on micronutrient status among the beta thalassemia carriers that is funded through ICMR because there has been concerns that have been raised that through the rice fortification, beta thalassemia carriers are prone to having, they are likely to have an iron overload. So all these four studies we will be covering. Two have been finished and two are ongoing, and we will be sharing the results to make you understand why it is important to start and be sure that we are having a very integrated implementation with the state as we are implementing this. For the Haryana demonstration project, the government of Haryana, the then NHM mission director, Professor Rakesh Gupta, Dr. Rakesh Gupta, had reached out to PGI Chandigarh and CDC to launch a project on wheat flour fortification. And this was an initiative which required a multi-sectoral coordination, where we had international partners with the World Health Organization and CDC from USA come together to give technical assistance to PGI in partnership with Government of Haryana to implement this project. The aim of the project was to assess the feasibility, sustainability, and health impact of fortifying wheat flour using existing open market and government safety net systems, which included PDS, midday meal, and integrated child development services. The project was supposed to run from three phases over 5 years, from 2017 to 2021, but the actual planning actually started in 2014. And between 2014 and 2017, there was a lot of interaction with the international partners. The project was developed. The lab that was supposed to test the folic acid was because we did not have a lab to test folic acid by a certain method that CDC used to test the levels of the biomarkers. That required a setting up of lab at PGI Chandigarh and training at CDC before we had to start the study. So that was completed around 2017 before we actually went into the field. So the three phases over 5 years required baseline household and biomarker survey from 2017 to 2018. Following the results that were shared with the state government, the implementation of wheat flour fortification started in the district of Ambala in March 2018. And in phase 3, it was an inline household and biomarker survey to measure the fortification program that impact in Anglo 2021. So the project sites in Ambala we chose the districts of Ambala and two blocks of Narayangarh and Barara. And in this, we randomly selected 52 villages, and they are the enumeration blocks of around 55. So you can see the distance of from the Narayangarh in Narayangarh. We have given given from the Narayan District Hospital what was the time what was the distance from the Narayangarh sub-district hospital, where we had opened a like a lab that was going to be processing the blood sample. Where you see, like from Narayangarh, the closest, there was the closest, and then in the from Barada, the distances increased. So this was important because we needed to maintain the integrity of the blood samples for the data to be shared. So the phase one included a multi-stage cluster probability household and biomarker survey. The study population that we had targeted was a non-pregnant women aged 18 to 49 years from the rural areas of two sub-district hospitals and sub-districts in Ambala. Venous blood samples were collected among non-pregnant women aged 18 to 49 years. The lab processing was done for the plasma, serum, red blood cells separated by centrifugation, processed, and stored at minus 80 degrees Celsius until analysis. So this entire process was done at Sub-District Hospital in Narayangarh. The RBC and serum folate were measured using the microbiological assay that was done at PGI Chandigarh. That was the lab that was established at PGI Chandigarh in collaboration with CDC, where the head of the like the hematology department, Professor Reena Das, and a lab technician from the same lab were trained under the guidance of CDC to establish the lab. So this technical partnership helped us establish the only lab, the microbiological lab assay, in addition to a lab in the private setup that is at St. John's in the Southeast Asia. The more labs were established following this successful establishment, but these were the first two labs that were established in the Southeast Asia at that time. And serum vitamin B12 was measured by chemiluminescence, and hemoglobin was analyzed using the automated hematology analyzer. In the phase three, so I am skipping a lot of the steps that are there just to ensure that in the interest of the time, so that you know what has happened. This entire process of implementation took us from the results of the pre-fortification, the where the program was following the result sharing, where the fortification program was established, to post-fortification impact at phase three. The fortification was introduced in March 2018 after we had shared the results of our study in the pre-fortification. The government of Haryana was convinced. They started they rolled out this into two districts, the entire district of Ambala, which was then expanded to 5 districts of Haryana. But in the meantime, as we were sharing, we were rolling out this entire through the PDS, the government of India actually changed the standards of the fortification of the 3 standards, and the standards that were there for vitamin B12 and folate went much below the WHO level. Their standards were iron did not change, but vitamin B12 and folate level standards were decreased. This is important to know because um, there is a now increased awareness around the standards, and there's a lot of advocacy that is going on to relook at the standards that are being there. And the study is important because we knew that the standards have changed. We had requested the government of Haryana at that point that in the interest of the research and the scientific integrity, if the standards that we had shared and used at the time of introduction at the pre-fortification that was decided, to continue the same standards in those 2 study blocks. So those standards were maintained, the same standards that are recommended by WHO in these 2 blocks. So at this point, this is the only study that we have the standards that were recommended by WHO at that point. The current standards that are being advertised, that have been recommended by FSSAI, are much lower than the WHO recommended. So any evidence that is being generated in the bid to revise the standards, this is one of the main studies that we have to show that why we require improved standards for vitamin B12 and folic acid. So coming to the post-fortification in phase 3, there are a comparison of pre and post-fortification adjusted geometric means concentrations, serum and RBC folate, serum vitamin B12, hemoglobin and ferritin was checked among those who had reported purchasing PDS fortified flour and those who reported not purchasing PDS fortified atta in the same population that we had tested at the time of the baseline survey. Comparison of pre and post fortification adjusted prevalence of folate and vitamin B12 and iron deficiency among the purchased and non-purchased group was done. So I mentioned, so we had 52 villages, 55 enumeration blocks in the both districts. Household survey was done in 1,115 study participants. Non-pregnant women of reproductive age survey were identified in 933, and non-pregnant women of reproductive age group out of this, age 66 consented to give the sample. In phase 3, when we went back after the study was implemented, in the meantime, I would like people to remind that we had a huge, there was a COVID, there was a pandemic, and the study was actually done during the period where the pandemic was there in the entire population. So at that time, the government of Haryana actually also introduced a policy where we said 3 kgs of fortified flour and 2 kgs of millet. But this was a time when we had gone to the field. We wanted to see, like, even before we went into the field, that if the people were actually having the flour. So it was found that most of the people, probably because of the COVID, were actually consuming the flour, over 90%. Out of that, I think between 60 to 70%, I do not have the exact numbers, felt satisfied with the quality of the flour that was being distributed, but there was a significant number which were not actually satisfied with the quality of the flour. But because it was at the time of COVID, and the people who were consuming it did not have much choice. And so there was a very high acceptance and consumption during that period. So the food insecurity part, that time of the COVID, actually PDS completed that entire part. So that's why even the people we were able to contact had actually had their flour and had it during that period of time. So when we went back at the time of phase 3, we had information of around 545 people who had, whether they purchased or did not purchase, but were enrolled in the PDS fortified article. So as you can see, out of the total, 128 did not purchase out of the total 545 that I had mentioned, but 417, that is a majority, actually reported purchase of PDS fortified atta. So what was the profile of the people who did not have the atta? So again, you can see most likely it was a general category that did not purchase the PDS fortified atta. If you belong to the other backward classes and scheduled castes, you are more likely to have the PDS purchasers who took the atta. Again, education played a major role where we see there is a significant, like people who are higher educated were less likely to have purchased the PDS fortified atta as compared to, uh, uh, I think, secondary and above as compared to people who had no education. So pre and post fortification comparisons. Overall, if you see, when we started the study and when we stopped the study, overall, the optimal RBC folate concentrations had improved. So this is called as a population effect. So even when you are going, and since it is a population-based study and the research team is there, so there's a lot of dissemination of this regarding the eating of healthy food. Overall, the RBC folate levels had improved. But what was striking is The levels in the purchaser group was much higher and it was above the recommended RBC folate concentrations of prevention of neural tube defects in the uh, among the participants who actually consumed the fortified flour, as compared to the people in the non-purchaser group, which were likely to be more educated and belonging to the higher caste, but probably because they had a higher higher ability to purchase, they probably went for a healthier food, but it was still not enough because probably it was less fortified. Because in the general market, the most of the fortified food that was available was as per the new FSSAI guidelines. They were not using the fortified food that had the fortified flour as per the previous WHO guidelines. So this was a stark difference that you can see. So this is again that we can see the difference was significant in the pre and the post fortification among the non-purchaser and the purchaser group. Same for the serum vitamin B12, where both non-purchasers and purchasers pre and post fortification comparisons have shown overall improvement in the micronutrient levels. Hemoglobin levels again it is similar. And as you say, even if the non-purchaser group was ability to purchase in the market, the iron levels remained similar in the levels that were identified through FSSAI at that point. There was no change in the iron levels in the new guidelines. In fact, in the ferritin, the non-purchasers, it was more. And this is the overall that we can see that there is a significant reduction in insufficiency, deficiency, and in both RBC folate, serum folate, vitamin B12, and anemia. In summary, there is an increase in adjusted geometric mean concentrations of all studied biomarkers post fortification, decrease in adjusted prevalence of folate and vitamin B12 deficiency, insufficiency, anemia, and iron deficiency among the purchasers and non-purchasers of the PDS fortified atta. Purchasers of PDS fortified atta, RBC folate, geometric mean concentrations are greater than 748 nanomole per liter, which is the optimal RBC folate concentration for neural tube defect prevention. With this, I will be stopping to just come back. Yeah. 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 Dr. Patel, if you can just ask if there are any questions around this, because then it is the next study that you will be starting. Because this is something that as we go along, I wanted to be more interactive rather than just that me speaking and not trying to understand.
Yes, ma'am. I think you can continue, and at the last we'll ask if.
Okay.
Thank you, ma'am. Thank you so much.
Yeah, thank you. So as we are starting the next, and I'll be asking Dr. Gajendra to take over. Just to give you the summary, the study might seem small, but just to give this the perspective to the students who are sitting, this required a lot of coordination and advocacy at every level. So anytime you think how the research impact has to be at scale. So people who actually were working with us in this area actually got trained and went on to, like, when we started the plus F certification and were trained at Haryana, went on to occupy the highest positions at FSSAI. So just doing a good project and you have good people who get trained, they do get picked up to lead at the policy level, especially in the administrative region. So I think that is where there's the beauty of a well done project, where there's a lot of advocacy and it's done well, and how it impacts. Because if you, this is the capacity building, there's advocacy, and the people who do the capacity building, if they are able to occupy at the policy level, it can impact the entire country. So this is something that we can talk about as we are taking, but that is why I said anything you do at the level of the implementation research needs to be included at the level of the state or at the policy level. So there is a lot of intersectoral coordination and the implementation is for scale. So this project went on to this, and it was a precursor of the national tree fortification policy that was announced by Prime Minister of India for the rice fortification in 2000, I think it was around 2020, 2019 for the rice fortification. So with that, I think I'll ask Dr. Gurjinder to take over. But this is again, I will request the students to think over why we need fortification and what is the population level that we are looking at. We took a problem, we identified the population, we coordinated with the state, and the food security part actually came in when the COVID pandemic came in. So all these three things actually come into play when we are talking about. For this, I hand it over to Dr. Gurjinder to take it from there.
Okay. Hello everyone. Am I audible? Hello. Yes, ma'am, you are audible. Yeah, thank you so much. I myself, Dr. Gurjinder Lal. I work with Dr. Mona Dukal and Dr. Reena Das. So I was part of all these studies, and now Mona ma'am, she has talked about Haryana demonstration project on wheat flour fortification. Now I'll be discussing another three studies. One is on salt fortification, then another on rice fortification, and then intacta fortification on thalassemia carriers. So last month I visited this Central University of Haryana, Mahendragarh, to give a lecture on rice fortification. Also, I met Tejpal Deva sir. So today I'll be discussing my experience, how we worked on various vehicles of fortification, that is wheat, which is already discussed by Mona ma'am, and then salt, rice. So this study, which you can see on the screen, effect of genetically fortified salt on micronutrient status of non-pregnant women of reproductive age in Punjab, India. So we have seen the impact of fortified salt on the micronutrient status of women of reproductive age and also preschool children. So the goal of multiply fortified salt study was to evaluate the impact of quintuply fortified salt. Quintuply means we have added 5 micronutrients with iron in the form of encapsulated ferrous fumarate, zinc, vitamin B12, folic acid, and iodine versus quintuply fortified salt with iron in the form of encapsulated ferric pyrophosphate plus EDTA, zinc, vitamin B12, folic acid, iodine versus iodized salt. So we have used 3 type of salt. So it was a totally blinded study. So we didn't know which packet has which type of salt. So basically, in India, in the doubly fortified salt, government usually uses the encapsulated form of iron, that is ferrous fumarate. But the studies showed that the acceptability of ferrous fumarate salt was very less. So we wanted to try the other type of iron also, that is encapsulated ferric pyrophosphate with EDTA. So this study was conducted among non-pregnant women of reproductive age and preschool children. So we took mother-child pair in our study to to assess the impact. So this study was done in 2 phases, phase 1 and phase 2. So in the phase 1, it was a cross-sectional study in which we enrolled 100 women of reproductive age, and we took their blood sample and we assessed their micronutrient status. So it was a baseline survey so that we could, get an idea what is the prevalence of the micronutrient deficiencies among women in Punjab. So based upon those only, so we have made our salt, fortified salt, and we have given it to the community for 1 year. So in the summary of phase 1 findings of 100 non-pregnant women of reproductive age, it showed that anemia prevalence, then iron, ferritin levels, and then B12 deficiency, folate deficiency, it was quite high among women of reproductive age. You can see the anemia prevalence was 37%, ferritin was 67%, and if you can see vitamin B12 deficiency was also 60%, and RBC folate deficiency was approximately 70%. Other micronutrients, they were also very deficient among women of reproductive age. So these were the findings of phase 1 of 100 non-pregnant women of reproductive age. So based upon the results of phase 1, we have designed our phase 2. So in the phase 2, it was a double-blind, randomized, controlled, community-based trial. So the study groups which I have already discussed were salt fortified with iron in the form of ferric pyrophosphate plus EDTA, zinc, vitamin B12, folic acid and iodine, and then another salt was fortified with iron in the form of encapsulated ferrous fumarate, zinc, vitamin B12, folic acid, iodine, and third salt was iodized salt. So all these salts were totally blinded, and then primary study population were women of reproductive age, and so in these slides I'm showing only the results for women of reproductive age, but we have included preschool children also. The eligibility criteria for the study was a woman should be between the age range of 18 to 49 years at the time of enrollment, and they should not be currently pregnant. So we have confirmed their pregnancy through urine pregnancy test, and then they should not be severely anemic. That is, their hemoglobin concentration should be more than 8 gram per deciliter, and they should be permanent resident of the study village, and they should not have any serious health issues, and they should be willing to use our refined salt provided by study as a primary source of household discretionary salt, and they should be successful, and they should be willing to give their blood during the blood collection. So the duration of intervention was 1 year, that is 12 months, but it was for cohort 1, but we have faced lot of exits during that 1 year. So we have taken the cohort 2 also, that is on another 200 women of reproductive age, and their follow-up was only for 6 months. But for the originally recruited women of reproductive age, their follow-up period was for 12 months. The study setting was 34 villages of Mohali district of Punjab. So these were the different villages which in which we have conducted our study. So so there were like different activities for the study implementation, like starting from the sensitization of the community leaders. So before even the sensitization of community leaders, so we talked to NHM officials. We took their permission to conduct a study in Punjab, and through them, then we visited the SMOs of the Mohali district, and then we took their permission, and then we did the sensitization of community leaders and potential participants, and we started that in October 2022. After the sensitization of community leaders, including ASHA, Panch, and then potential participants were women of reproductive age, and then we started the screening and enrollment. So how we did the screening and enrollment? Like first, on the very first day, we did their sensitization, and then we convinced them to use the fortified salt, and those who were interested, we went to their household with the help of ASHA, and then we screened following the eligibility criteria, and on the very next day, so we have given them a enrollment card so that they should bring on the next day for sampling, and then we took the blood collection, and then they at the common place only, and then we did the anthropometry and biochemical assessment, and at the common place we did the randomization for all those three type of salt. So the salt was totally blinded. So three types of each salt was divided into two colors. So there were total 6 colors for these three types of salt, and then the different colors for colored packets were randomized to the study participant, and then they were asked to use the salt for the whole household for like 1 year. And then we did the weekly visits for 6 weeks also, so that to check that whether they are using the salt or not. And then the monthly follow-up visits were also done, in which because we were providing only 1 month quantity to the whole household, and then after another month we were giving the salt again, and we were following this thing for 12 months. So 12-month follow-up period was done for cohort 1, and if you can see, the cohort 2 is for those newly enrolled women, because for cohort 1 there were a lot of exit rates and then biochemical assessment of micronutrients. So in the picture you can see, so there were different 6 color packets of salt. So each type of salt was divided into 2 colors, and we have given a container also to the study participants, so that, and the storage instructions were also given to them, like they should not keep it in the lid open, the container's lid should not be open. And then the opaque 500 salt packets were given, and the monthly visits to deliver salt to participant home. So how we have chosen that how much amount should be given, it was based upon the household size. That is, if a household has 1 to 5 people, then 1 kg of salt will be given to that household for per month. If the household size was 6 to 11 people, then we have given 1.5 kg per month, and then if the household size was more than 12 people, then we have given them 2 kg of the salt per month. Then during this 1 month interval, if any household they require extra salt, then we have given a supplementary supply also of 500 grams of salt to that household. So this is the flow chart of the study. So at baseline, we have screened 1270 women of reproductive age, out of which we have randomized. In the randomization, we will say that successful enrollment of women of reproductive age who accepted our study salt were 998. So these 998 women of reproductive age, they were categorized into 3 categories of based upon 3 types of salt. Then each category had around 333 women of reproductive age, and then out of these participants, various participants they exited during the first 6 months of study only. That is, 42 they exited from iodized category, and then 58 from ferric pyrophosphate category, and then 57 they exited from ferrous fumarate category. So at baseline we took the blood sample, and then at 6 months also we took the blood sample, and then at 12 months also we took the blood sample. So there were total 2 cohorts. Because our sample size was 798 for women of reproductive age, and those who were enrolled at baseline, 20% exit rate was there. So we had to re-enroll another 200 women to compensate our sample size. So there were 2 cohorts, cohort 1 and cohort 2. So if you can see in this graph, so first I'll tell you, in the phase 1 where we only did the assessment study of 100 women of reproductive age, so we assessed their daily utilization of iodized salt only. So daily utilization was approximately 6 gram per day. So when we found in phase 2 for fortified salt consumption, it was approximately similar to how they were using their iodized salt. And then the fortified salt consumption, it was uniform across all these 3 types of salt categories. In phase 2, so this table indicates the characteristics of study participants by intervention group at baseline. So the age range was 31 year in iodized salt category, then 32 in ferrous pyrophosphate, and then 32 years only in ferric fumarate study. So so we have divided them into different salt categories. So approximately 8.7% of the women, they were working uh, in all the categories, and then body mass index was also uniform, that is 25. They were obese, they were in the obese category, and then anemia prevalence was 45% in iodized category and 50% in ferrous pyrophosphate and 48% in ferric fumarate category. So the result for so this slide indicates the results for vitamin B12. So you can see that serum B12 deficiency was 40% higher in both. Serum B12 concentration was 40% higher in both QFS groups versus iodized salt groups at 6 months and 12 months. If you can see in the graphs also, the blue bars indicate baseline, red then 6 months, and green bars indicate yellow, green bars indicate underlying category. So the B12 deficiency was decreased by 6 months and also by 12 months in both encapsulated ferric fumarate and encapsulated ferrous pyrophosphate compared to iodized salt category. So effects of HONO-TC, MMA and homocysteine were also consistent. For folate also, RBC folate was 57 to 71% higher in QFS groups versus iodized salt groups at 6 months, 12 months, and odds of folate insufficiency were at least 80% lower in QFS groups versus iodized salt groups at 6 months and 12 months. Effects on serum folate were also consistent. For zinc, mean serum zinc was 2.1 microgram per deciliter higher, and odds of hypozincemia were 38% lower in encapsulated ferric fumarate versus iodized salt groups at 6 months. Non-significant increase in serum zinc and reduction in prevalence of hypozincemia in encapsulated pyrophosphate 23 fortified salt group at 6 months, and no difference was found at 12 months. Similarly for iron, so we have found our results significant only for D12 and folic acid only, but they were non-significant for iron, as there was non-significant increase in ferritin and decrease in serum transferrin in encapsulated ferric pyrophosphate ferric fumarate versus iodized salt group at 6 months. Non-significant reduction in iron deficiency in encapsulated ferric fumarate versus ferric pyrophosphate and iodized salt groups at 6 months and 12 months. And for hemoglobin and anemia, no differences in mean hemoglobin concentration or the prevalence of anemia across groups at 6 months and 12 months. For iodine also, we have not found any difference in thyroglobulin concentration at 6 months or 12 months. No difference in urinary iodine concentration at 6 months. And geometric mean of urinary iodine was slightly higher in encapsulated ferric fumarate groups at 12 months. Additionally, we did the qualitative study also. After 3 months of consumption, we did the qualitative interviews, and then at 6 months also, and then at 12 months also. So these qualitative results indicated that various participants, they were saying their views regarding the color, flavor, and other acceptabilities. So regarding the color, they were saying its color is bit strange, that is all whole white, which is this is a bit blackish color appears. It's all fine. Can we change the color? So, and then another participant was saying that it's look good like normal salt, but vegetables turn black when we put it in the dishes, and it has some medicinal taste also when we heat it, and it turns black. Taste is otherwise okay. So these were their, views regarding the salt color, because we ourselves also found that when we went to the field, when they were cooking, so then their vegetables were turning black. So people were thinking that we are not giving the good quality salt. But it was due to iron that their vegetables were turning blackish. And then regarding the flavor, participants were saying it looks like a bit less salty from other salts, and those are used less, but this one is consumed more. In these dishes, whatever we add, it always remains less salty. And then another participant, they were saying it is fine, it tastes good now. In the beginning, when we first started having it, it felt odd, and also more of this salt is required. So, to put in the vegetable, we put less with the other salt, other one. For example, 1 spoon is required with other salt, but now with this, 2 3 spoons are required. So, these were the views that their flavor also, the saltiness of the salt was also less in the fortified salt. Sorry, and regarding the size of salt grains also, the size is okay, but it doesn't get mixed. I told you that it doesn't get mixed. It floats and sparkles over the dish only like a whitish thing. And then other participants, they were saying in the grains, there is a bit of difference when added to buttermilk. The grains are chewable. Those grains have different taste. So these were the findings. So when I conclude this study by saying that encapsulated ferric fumarate and ferric pyrophosphate substantially improved the vitamin B12 folic status and lowered the odds of vitamin B12 insufficiency and folate insufficiency by at least 77%. At 6 months, serum zinc concentration was significantly higher and the prevalence of hypozincemia lower in the ferric fumarate versus iodized salt group. Improvement in zinc status were more modest in the ferric pyrophosphate group. Effects were not sustained at 12 months. Modest, non-significant increase in serum ferritin concentration and modest, non-significant reduction in serum transferrin in encapsulated ferrofumarate versus iodized salt group at 6 months. Encapsulated ferrofumarate group exhibited a non-significant reduction in the prevalence of iron deficiency at 6 months and 12 months also. Quintuply fortified salt did not reduce anemia in our study population. A response in hemoglobin may vary according to baseline anemia status. There were no differences in thyroglobulin or urinary iodine concentration across groups. So these were the findings. So this is our study team. So our collaborators were from University of California, San Francisco, Dr. Christine McDonald. And then we all are here. So Professor Ina, she was the main PI for this study. Then I'll talk about rice fortification. So we have set up a technical support unit with Government of Haryana in support with United Nations World Food Program. So under this technical support unit, we are doing various activities across Haryana. So this technical support unit has been formed at Department of Hematology in PGI Chandigarh. The MOU was signed on 19 October 2023 and the induction trainings were conducted in 2023, divided into 4 sessions and 2 field visits. So these orientation and trainings were given by WFP persons. So then now we are at PGI, we are independently doing the monitoring visits. We are conducting the public lectures throughout Haryana at medical colleges, universities, and other academic institutes. So several public lecture on rice fortification was organized across Haryana. All the participants were sensitized, which included HOD, senior medical officers, students from different departments and medical institutes. And then rice fortification sensitization lectures were also done at Poshan Pakwada in colleges across Chandigarh. And then we also, I'm also a member of this technical support unit, I along with my other colleagues. So we conducted, we also went for training at nurture program conducted by St. John's at Bangalore. So it was a 20-day program. So we also went there, and then we also got trained as master trainers during the gender integration in health and nutrition by Gender Health Organization. And then we are doing the independent monitoring and field visits to rice mills, schools, Anganwadis, then fortified rice kernel units, and sorry. So we are compiling these reports and submitting to WFP, and also we are meeting the government of Haryana and we are updating them regarding the progress of how rice fortification is being done and how people are consuming. So because rice fortification is given through various channels like PDS, then midday meal, then ICDS. So we are following all these channels, and then we are, if there are any drawbacks or anything is needed, we are supporting the government. And then another study, so this study has a history behind it. It is the impact of fortified wheat flour on micronutrient status among carriers of beta thalassemia. So this is an ongoing study. So when rice fortification was started in India by our Prime Minister Narendra Modi, so it started, and then various activists they started saying that fortification, basically iron fortification, it is leading to iron overload among thalassemia patients, and it is not good for them. But thalassemia, it is of two types. One is thalassemia major, and then another is thalassemia carriers. So thalassemia carriers are people having one gene normal and another having thalassemia on it, but they are totally normal until and unless they get tested for thalassemia. So they live normal life. They can also have iron deficiency and other micronutrient deficiency. So putting a warning label on fortified food that people with thalassemia or sickle cell disease, they should not consume iron fortified food. So it leads to some, misinformation among people with misinformation among thalassemia carriers also. And there were no studies across the world which showed that fortification is causing any impact on thalassemia carriers. So we have written a proposal to ICMR, and now we are conducting a study to assess the impact of fortified uh, food on micronutrient status among thalassemia carriers. So so basically, these are the primary information which are indicating that beta thalassemia prevalence is only 3 to 4% in Punjab, and they are thalassemia carriers. They are asymptomatic. That they can also have iron deficiency, anemia. Their iron deficient stores are also there, and there is limited data on iron and micronutrient status in thalassemia carriers in countries and with iron fortification. So the objective of our study is to screen screening of beta thalassemia carriers. Just 1 second, minor. Uh, 1 second. Sorry. Uh, So objectives of our thalassemia study is to screen for beta thalassemia carriers, that is beta thalassemia trait, in districts where fortified food is available and not available through public distribution system, and assessment of vitamin B12 deficiency, folate deficiency, anemia, iron status, and inflammation in the study area, and then comparison of anemia, iron status in beta thalassemia carriers in district where fortified food is available through PDS and where it is not available. And then comparison of folate and B12 deficiency among beta thalassemia carriers in districts where fortified wheat flour is available through PDS and where it is not available. So Our study area is Mohali district of Punjab. So it is basically a case control study. So we are doing the study in Punjab and Himachal Pradesh. In Punjab, no fortified food is available through PDS, and in Himachal Pradesh, government is providing the fortified food through PDS. So the total sample size is 6,000, which includes 3,000 from Punjab and 3,000 from Himachal Pradesh, and the enrollment of participant is 50%, that is 1,500 will be males and 1,500 will be females from each state. And if we found any beta thalassemia carrier, then the entire family will be assessed for beta thalassemia carrier status. In this study, we are collecting the background information on household socio-demographic characteristics and procurement of fortified wheat flour, utilization and practices, food security status, and dietary diversity. Participants will be scheduled for blood collection at the common place, which can be primary health center or Anganwadi center. And then peripheral blood collection, we are doing at 8 between 8 a.m. to 9 a.m. And then for thalassemia carrier screening, we are taking 3 ml blood sample. So this is the flow chart. So in this study, we have already completed the blood collection from Punjab, and then now we have started from Haryana. So total 6,000 samples will be collected, and from those we'll be screening beta thalassemia carrier status through Suzuka app, and then we'll also be testing their HPLC status, and then we will be comparing the results from both these states to assess the impact of fortification on thalassemia carriers. So the summary of all projects. So first, the wheat flour fortification, it improved the folic acid, B12, iron status, effective via PDS, midday meal and ICDS channels. Then multiply fortified salt study, it enhanced B12 and folate status and modest impact on zinc and iron and no change in anemia. And then rice fortification, so the TSU has been established and we are giving the trainings and sensitizations are being conducted and monitoring and field visits are also ongoing. And in thalassemia carriers, the ongoing assessment of micronutrient status in beta thalassemia carriers in fortified versus non-fortified regions. So challenges in implementations are there. There are limited awareness among communities, supply chain gaps like procurement, quality control and distribution, ensuring bioavailability and acceptability of fortified food, and sustained financing and interdepartmental coordination, which is a task because we have to take a lot of permissions, and then monitoring the impact at scale. So way forward is to expand fortified food distribution through PDS across more states, continue impact evaluation with robust biomarkers and surveillance, prioritize anemia reduction via complementary interventions, and train frontline workers and improve community awareness, align policies to support long-term, large-scale food fortification implementation, and integrate gender-sensitive and equity-focused approaches. Thank you so much. Any questions? So I know it was a very lengthy presentation and we have concluded 4 studies in this. Yeah.
Ma'am, definitely there are many questions. As you mentioned, your study was too long. So definitely there are many questions. So I would like to start from first. Is fortified salt equally effective across age groups? As you mentioned, different age groups you targeted.
No. So in our multiply fortified salt, the age one was women of reproductive age between the age range of 18 to 49 years. So the effect was uniform across the ages.
Ma'am, although reproductive age is also like different, it's the big criteria you used. So some are definitely unmarried one and few are married one, some have children as well. So is there any impact beyond that, like age के beyond आप कुछ effect?
हाँ, so मैम जो हमारी स्टडी थी ना, so it was so I'll first talk about multiply fortified salt study. So it was a combination of 2 studies. So funded by Bill Melinda Gates Foundation on women of reproductive age and another on preschool children by Pressure Foundation USA.
So we in our study we took mother-child pair. Mother-child pair. So those who were having the mother's age should be between 18 to 49 years of age, and children they should have a child between the age range of 1 to 5 years. So we were providing the salt to the whole household, not only that mother-child pair only. So everyone was consuming that salt, but we took the blood sample only from mother-child pair. And yes, the impact was uniform. So for because we have recently concluded this study, so we haven't checked the result of preschool children, but definitely for women of reproductive age, it shows a very good impact on reducing the micronutrient deficiency, especially folic acid and B12 deficiency.
Okay,
Yes.
thank you, ma'am. Another one is major challenges faced during double fortification products.
Doubly fortified, yeah.
This is
Hmm. So, except in W45 salt study, they use encapsulated ferric fumarate type of iron. So, but the acceptability was, as I have said, that there was acceptability issues. The people were not using. They were saying that dishes are turning blackish. The grain size was also not accepted. They were saying these grains they were floating on the vegetable curry or any buttermilk. So to just test whether we can use iron in the form of ferric pyrophosphate, so we have checked their accessibility, but the acceptability issue they are uniform across all these categories. So basically, when we started this study, this salt is quantitably fortified. 5 micronutrients are added. So we thought that in one category we should remove iron. We should not add iron so that we'll check the acceptability whether people are now accepting it. But then it was a bigger decision. But yes, acceptability was impacted by iron.
another one is, ma'am, does fortified salt influence lactobacillus growth?
So we have conducted this gut microbiome studies also, but their results are underway. So we haven't assessed those. So when we get those results, definitely we'll share. But as I've told you, it is a recently concluded study. We just assessed the micronutrient status only. So that thing is not checked yet.
Another one is, ma'am, how can findings from this study guide national fortification policies?
So we have developed a technically advisory group for this study. So various meetings were held with ICMR officials, FSSAI officials. So because salt is uniformly people are uniformly using it. So for example, rice, there is 65% consumption rate of rice throughout country. So few states they are not consuming rice, and similarly for wheat. But salt everyone is using. So if we do the fortification in salt, definitely it can go to the policy level. Yeah. So Dr. Mona is also with me.
Ma'am, what statistical methods were used to determine the impact of fortification?
Sorry, can you repeat?
Yeah, sure, ma'am. What statistical methods were used to determine the impact of fortification?
So regression method were used, ANOVA were used. So if you can see in the slides also, we used the linear regression and then multinomial regressions were used to check the impact of the micronutrients. These were the method. These methods were used, but we have the statisticians from University of California also. They were helping us to analyze the results.
Okay, ma'am.
कौन सा method use करते हैं linear regression में वो भी specific method भी use करते हैं I think for many of the fortification trials, if you see, for that we had done the geometric regression at that point. And there are specific methods that have been identified that have been now standardized over a period of time with the Emory University and CDC. So if you have a look at it, I think you will be able to understand. But they are much more like, I think, that requires a lot of training. And if you are interested, I think this is something that has to be taken up separately as a project.
Yeah, sure, ma'am. Uh, how were dropout rates managed or minimized during a such large scale study?
Can you just
Ma'am, how
can
we can reduce or manage the minimize the dropouts during the large scale studies?
Okay, that's a very good question. So many of the implementation research studies, specifically if you look, these are all studies that require extensive biomarker collection. So it is not very easy. So in both wheat and salt, generally for the biomarker collection, if it is the adult population, it requires a lot of community sensitization. There is a whole module how you have to sensitize the community. So village level, it is much easier. At the level of semi-urban or urban, it gets more difficult. First, because it is a more working class population, and also I think acceptance at the urban and the peri-urban areas, we are less likely to find the people at home at the time that we are looking for. Rural population, if you actually look, it is much easier because at the village level, you can actually you can meet with the sarpanch and the ASHA workers. It is a well documented system who you should be able to take under your. So for most of the biomarkers that were done at the rural areas, overall we were able to have 90% of the people we could go back and get the blood sample. 5 years is a big time when you go back. The most of the dropouts were generally because either the women got married or they had left the place. But for the people like if you have seen the multiply fortified salt, although the dropout was much higher when we had enrolled women with their children, but when we had only women without children which were enrolled, the overall acceptance and consent was at the level of 95%. But what goes in behind is that it has requires very good field staff who is able to convince, have the proper consent, and lot of community sensitization. So sensitization has to start at the level of the PHC or the local local PHC level where you have the SMO, then the ASHA coordinator, then the ASHAs, the Sarpanch, and the people who will be like key people like the Anganwadi workers and everybody, they need to be sensitized. And then, of course, the community itself. So that needs to be very strong so that the entire community is convinced that the intervention or whatever you are doing is for the community. And then you will be get a lot of compliance.
Thank you, ma'am. What type of side effects or tolerability issues were observed during this type of study? Fortified food, specifically as.
Okay. So, if you have been reading the literature, I think the biggest problem is the color because of the use of iron, both at the level of wheat flour and in the iron. So, in wheat flour, when the program was rolled out, one of the biggest caveats was that the color of the flour used to turn black. So a lot of so then the and the state machinery actually kicked in at the level of the BFLA where there was a behavioral change communication unit at the NHM level. They did a lot of this counseling and other things to ensure that this where they were getting the complaints, they went in, they actually talked about it to make sure that those effects were mitigated at that point because it was at the state level, population level. So state did the entire behavioral communication counseling part, and so that the acceptance was there. For the study, because it was an RCT in multiply fortified salt, again, our research teams, we made sure that they were available 24 hours for any of that to ensure that the compliance and if there was any problem, we used to go in, counsel them, and to ensure that whatever was being consumed was acceptable but we still had a lot of dropout rates because of the color. So color was a big issue, and that is something that we need to look in.
Okay. Thank you, ma'am.
Good afternoon, ma'am.
Yeah.
Ma'am, my question is among wheat, rice, and salt fortification, which one do you think has the biggest potential in India and why?
Uh, so I think it is a question that will require more studies at this point. We do have it now. The evidence is being generated at the India level. Because some of the micronutrients will do well at the level of which fortificant vehicle. That is something that now needs to be uh, discussed. So those conversations have started because if we look at iron overall we have realized the acceptance has been much poor as compared to and the impact also is we see because of iron the acceptability of the overall fortificant vehicle has gone down. But if you remove like iron, probably the acceptance of the other like vitamin B12 and folate might be more. So those conversations have started and to see like is biofortification is a better method for iron and for salt, which is a fortification for like as a fortificant, which fortificant level needs to be discussed. And because if you know like iron, like with salt, now the general trend is we are recommending that it should be less than 5 grams because of the hypertension that is associated with it. So how much fortificant can be added to the salt and how can we maximize the impact at the level we want to use so that we do not increase the other problems. Similarly, I think the consumption we see rice. Rice is majority, it is consumed in the southern states. 40% is like the wheat flour fortification, that is the belt of UP, Rajasthan, the northern states, that is a 40% that consumes wheat. So at what level, which fortificant is going to be important, that needs to be done. And salt, we have realized, is probably easier to manage, and the quality level might be easier if we see. But then it is like how much salt is good and how much salt is bad, and how much it will be able to do as a fortificant. Rice, again, it depends because with a lot of the eating habits, especially in the urban areas, a lot of people are eating outside. It is not being consumed now like that. I'm not cooking the food. So this is something again as a debate and more studies required to be done.
Okay, ma'am. Thank you, ma'am.
Good afternoon, ma'am. Madam, you were talking about that adjusted geometric mean, but if we had just taken a simple mean, we could have also identified the outliers on the extreme deficient levels, and we could have identified them for further management.
Yeah, so geometry, so this is the first level of analysis that we always do. The geometric mean part was done as the next level, just to ensure whatever we are doing, because I'm not a statistician and I will not be able to answer the questions that you have asked to the in a technical language. But what you have said is exactly that was done before we actually moved to the geometric mean, and we do have those detailed analysis in the report that we had done. So geometric mean is like the final. I think I'm forgetting the name of the method that we generally use that is done. I'll get Dr. Tejwal. I will get back to you. I think this is something that we have. That is a standardized method that we use for in fortification. I think Dr. Helena might have even talked about it earlier. So I'll get back to you with the method that is used and why we use the geometric mean. But this is the first level of analysis that we have said we have done it before we move to the geometric mean.
Madam, one more question.
Yeah.
You added EDTA to the ferric pyrophosphate, but not to ferrous fumarate. That is because of ferrous. What is the reason?
EDTA versus in the salt. EDTA in capillary. You want to answer that question? I think it is. Can you repeat the question?
Madam, EDTA was added to ferric pyrophosphate, but not to ferrous fumarate. Why?
Okay. I think when this was a question more about regarding like more on the physiological side. So our partners at St. John's, they were actually looking at the physiological studies when we were doing it. So this was more related to when it is goes to the gut, how much is absorbed. So that is something that is like for the final recommendations. If we add a particular thing to the like the salt, like EDTA, how much is it absorbed when it is ingested in the blood levels, and how much it is increased. So that was more of the question on the physiological side. because I think it was around the acceptability and something around the physiological side, and like from the gut, how much is absorbed to make a difference in the at the biomarker level.
Good afternoon, ma'am.
Yeah.
How can multi-sectoral collaboration between government agencies, private industry, and civil society be enhanced to improve the implementation and sustainability of food fortification initiatives?
So this is a project that is a perfect example of that. So it was initiated at the level of the government. It was taken up by our development partners. So the entire advocacy was actually done. I think it was initiated at the government level, but even at the government level, for to scale up, the entire advocacy was done by our development partners that included FFI and GAIN at that point. And now we have the World Food Program that is there. So that is the first part. At the at the private sector level, when we had identified what are the levels of the salt we are looking at, the salt packets were actually done at the level of JSK, that is a private firm in Rajasthan. For the wheat flour, we had identified millers who required a lot of training how to do the wheat flour, and but to give the stamp, being the distribution was at the level of habit, because the PDS system, we wanted the something that was acceptable to the local population. So Hapid in the Haryana has a very like good name, and it is like uh, you can say it is equivalent to the quality. So if Hapid is distributing the PDS or through the PDS, that means the quality of the flour that was going to be given to the consumer would be of certain quality. So Hapid tied up with the local millers. So they were the main distribution with the Hapid stamp on it. So this is a perfect example. And then we had the women and child development thing, because the midday meal was also included in this. So how the fortified flour went to all this, and it was done at the level of the PDS, at the women and child development, at the level of midday meal, and the ICDS level. So this is the entire intersectoral coordination. And because it was at the policy level, it started at the districts, like in the two blocks, scaled up in the district of Ambala, followed by scaling up at the five districts in Haryana. At the national level, again, this entire process, because we had trained the capacity building, the person who was heading the NHM was then the in charge of the fortification at the national level at FSCC. So you can see at every level the coordination was there. It was private, it was government, it was the development partners, and of course we had the funders from across. Like we had the government funding the program, we had the ICMR funding the program, we had the Gates Foundation funding the program. So it was a lot of intersectoral coordination, and even the part that we are now sitting for the GYAN course, I think Dr. Tejpal will allude to it. We had the entire fortification course, I think 2 years back, where we had people coming from MD to give the coursework, and there has been a lot of capacity building since the program has started.
Thank you.
Good afternoon. Can you be louder?
Good afternoon, ma'am.
Yeah.
Ma'am, during the different projects that you've done, you've fortified using B12. What is the source of B12 that you've used while fortifying the wheat flour, salt, or even rice?
These are all chemical fortificants. So I think this is something that it is not, we are not use any biofortification. These are standardized, like the government, whatever they have identified, the sources of, like where you have to procure the fortificant. So they are identified partners within the field, which from where that is procured.
So you
So that is
mean
something, yeah, something that we were not involved as academic partners. This was actually taken care at the level of, like we had other partners who took care of that. But it was actually standardized process when we had done it.
so do you mean that there are chemically like we can create B12 in the lab?
No, this is a chemical fortificant, and it was like we have identified, sourced it from the industry.
Yes, ma'am, but ideally speaking, B12 is supposed to be sourced either from animals or it is formed in our gut microbiota, right? So,
I
how would
totally
you
agree.
formulate it in
At
the
that,
lab?
yeah, I think this is again, that's what I said. It's good that you're starting to think how you want to source it. At this point, it was more about how do you integrate it within a like a fortificant vehicle, and this is totally a chemical fortification part that we will do.
Thank you, ma'am.
Good afternoon, ma'am.
Good
Ma'am,
afternoon.
my question is that during your fortification study, do you come across any interaction of the fortified nutrients with those that was already present in the wheat or rice, like folate or B12, hindered or supported any nutrient that was already present in the wheat or rice?
I haven't done these kind of reflections except for cut fine program. So
We were collecting supplementary
we
fertilization data.
so there were two ways to do it. So we have done a sub study. I think the results should be out at any point. The gut microbiome study with the total intention and the multiply fortified salt. But we did take the data of the supplementation or like and the other vehicles that might be fortified. But there was no way to test it, and we have not actually looked at it. This is a further question that has come out from the recent studies because there are now multiple vehicles of fortification. But this was not a research question. But we are in the process of publishing the microbiome study where we have actually started to look at whether having these multiple fortified vehicles on which we have the information, if that had an impact on the gut microbiome. It is a small study. I think, as of now, it shows that there was no interaction, but I think it requires a much larger sample to test that. But this is again that has been now identified as a future research question that we want to take up as we go forward.
Okay, thank you, ma'am.
Good afternoon, ma'am.
Yes, good afternoon.
Okay, ma'am, as you said about iron fortification food by salt and wheat. So, despite years of supplementation and fortification, in your view, what are the key gap in the implementation that young researchers should focus on addressing?
Okay, so fortification has just started, so we are still dealing with implementation challenges. So I think we have to give them. So any major impact, especially in the field of fortification, that we need to see is actually at least 5 years. So generally we say like if we want to say birth defect has decreased, which is the gold standard of any impact outcome that we are looking at for especially vitamin folate acid, that program has to be there in for implementation at least for 5 years. Regarding supplementation, because this has been a program that has been long now, it has been implemented. One of the major challenges has been again the quality of the tablets that has been given at the field level. So there has been a lot of resistance and a lot of challenges, and people have not, like especially women, they have had a lot of gastric issues. So most of the women who have taken this, the feedback has been that they are not able to digest. And other programs is like because of the black stools and the other problems in the gastric distress and everything, overall acceptance of iron has not been good. So those have been the challenges, and I think the major thing has been how we can identify other vehicles where we can deliver iron without facing the same challenges. That is how fortification came into the picture. But the overall quality, because of the metallic taste, poor implementation of the program, and inability to counsel the women of the importance of that, these have been the major factors which have been done. Again, because of this, I think now under the new anemia Bharat program, if you are following, it is now You identify and intend to treat, you identify and you go after the person who has that problem with anemia and treat it even further with the intravenous iron. That is a new methods that we are doing. I've not been following it, but now this is where the government is. We do not want to leave any patient in the field if it has been identified without being treated.
Okay, thank you, ma'am.
Is there any other question? No. So thank you very much, ma'am. Thank you, Dr. Mona, ma'am, for a wonderful lecture, and you have nicely connected the government policies and strategies, and you have shared your practical experiences during this session. So we are grateful to you, ma'am, and we are also equally grateful to Dr. Gurjinder, madam, for sparing the time. So, Mona madam and Gurjinder ma'am, thank you very much, and we hope to see you in our campus soon.
Yeah.
Thank you, ma'am.
And Dr. Keshwal, I know there were some questions that would require a broader answer. I will get back to you on that.
Sure, ma'am. Thank you. Thank you so much.
So especially the statistical part and I know the EDTA part. So we'll get back to the experts, and I think because it would be good if they get their answers. We'll get.
Sure, ma'am. That would be nice, ma'am. Thank you.
Yeah, if you can
Thank
just share the questions, we will get back to you with the written answers.
Sure, ma'am. Thank you. Thank you so
Thank you.
much.
Thank you.
Thank you. Thank you. Thanks, sir.
With this, we conclude the second session of the day. Everyone is requested to have their lunch and join us for the next session after lunch. Thank you, everyone.